record it. We'll do that. Share my screen again so everybody can see. Very good. So you should have a screen up there that you can see diagnostic imaging for physical therapists. I may have to back out in case I see any more people pop in. But my name is Mike, and I'm really pleased to be here today. Let me admit a couple more folk. All right. All right. We're good. And I think if folks have any questions as we work our way through, we'll go ahead and I can answer those. If Liz wants to go ahead and just, no, I'm good. I took care of that. So we're taping. And if folks have questions as we work our way through, let's go ahead and answer them. I can certainly do that. Just throw a question in the chat and we can do that. I'll try and stop about 10 minutes early and leave some room for questions. And so stop at 10:02. Get another person in here. Very good. And objectives for the presentation. This is probably a little more robust in terms of objectives, but I think today we'll talk probably mostly about the components of a radiographic exam. That's what we're going to talk about, and as well as the systematic approach to the analysis of plain film radiography. And we'll talk about why that's important. We probably won't get to CT, MRI, and bone scans, but we talked about maybe doing a couple of these that would lead into that. And the next step for this would be some of the more advanced imaging and talking about some of the stuff behind that. I'm sharing again. Share. Okay, good. So just a couple thank yous first to Krista and the Arizona and Wyoming chapters. Very grateful for the chance to talk about a topic that I think is extremely important. Thank all of you for taking your valuable time in an afternoon, evening, for attending. And talks like this, really develop over time. And really, all I am here really today is the messenger for, a lot of work that's gone on behind the scenes for a lot of different people. And I want to thank Michael Bain, Christy Green, and Ryan Elliott, who are physical therapists from Kaiser Permanente Vallejo, where I did my fellowship and had a chance to work with them well over 20 years ago now. We've all remained very close colleagues and all have an interest in this content. So the reason we're here today is, right, why is an understanding of diagnostic imaging necessary for PTs? And we'll talk more about that as we work our way through. But the bottom line is, diagnostic imaging is nothing more really than a special test. And it's a test that we can use to augment all the other things that we do in clinical practice. And so we'll start with a patient case. And so this is a 61-year-old male. He's referred to PT 3 weeks following an L3-4 discectomy. Okay. And if you look at his body diagram, it's a little bit complex, right? So he has low back pain, this intermittent ache. So it kind of comes and goes. If you look at his right hip, he has pain in the groin region. That's intermittent sharp. And then he has a lateral component to it as well. That's intermittent throbbing. And it kind of wraps around a little bit to the posterior hip. His worst pain, though, is his constant low-grade ache that he feels along the medial aspect of his right knee. And that's really the one that bothers him the most. And again, normally if you work with patients with spinal disorder, especially post surgery, you probably don't see these folks unless they're not doing well. And so the bottom line is 3 weeks after surgery, L3-4 discectomy. I'll show you the films here in a second. He's not doing well. He's actually worse after the surgery. And the surgical indications, there were several, but first off, He had severe low back pain and that right lower extremity pain that we talked about that kind of was into his hip and then into his knee. Um, what person in the room here? And he also had weakness in his quadriceps, right? So you think about the L3-4 nerve root, right? I'm sorry, the L3-4 disc, and I'll show it to you again in a second. That is going to contact or compress the L3 nerve root, which innervates the quadriceps. So we know that his quadriceps were weak, and his MRI showed a large herniation at the L3-4 level. And so these disc herniations, when we talk about them, we're not going to probably get into these tonight, but you can classify these in terms of whether or not they're just kind of a bulge or a protrusion or an extrusion. The extrusions are the worst. And you've probably heard that, if we do MRI scans on folks that are over 50, you're going to see pathology in the vast majority of those folks, even if they don't have symptoms. And that's truly the case. However, this type of a
Keep
hernia,
missing the beginning.
this extrusion here, we don't typically see in folks that are asymptomatic. So this is a unique herniation that we usually only see in individuals who have low back pain and usually radicular symptoms. So the sagittal view is on your left, cutting the patient in half from right to left, then the axial view is on the right. And anytime you look at those axial views, we're looking up, right? So the patient's feet would be out toward you, right? And their head would be back toward your screen, behind your screen. So that left side is on your right. Okay, so again, large herniation. They went ahead and treated that. And you're seeing him now 3 weeks following that surgery. So he's walking with a rolling walker, right, due to the low back pain and the anterolateral right hip pain. Bottom line, though, is that he has right hip range of motion that was limited and painful. And you say, well, why would you assess that? Right? If you're seeing someone 3 weeks following surgery, right, there's not, and they're really, really severe and irritable, sometimes there's not a lot that you can do except maybe evaluate joints maybe above and below the area. You can certainly palpate and you can certainly do a good neurologic examination. In this particular case, they went ahead and looked at his range of motion. And that right hip, was limited in terms of flexion, internal rotation, abduction, which, thinking back to your PT school days, that's a capsular pattern, right? So if there's something intra-articular, those are the classic movements that are likely going to be limited. Crepitus was also noted when you evaluate his hip. And the most telling signs were that he probably couldn't flex his hip to probably more than 70 or 80 degrees, and no internal rotation and no abduction at all. Strength testing is always interesting because, if there's pain in a joint and you decide to strength test it, you don't know if there's true organic weakness of the muscle or if we're dealing with pain inhibition related to the lack of performance from the muscle. So in this particular case, all the hip musculature that was tested was weak and painful, right? But the right knee extensors were just weak, right? Just weak. There was no pain associated when you tested his quadriceps, but the hip musculature, weak and painful. And then the knee extensors, those were just weak, right? Just plain old weak. And so, you'd ask yourself, what would you do at this point? What would you do at this point, right? He's 3 weeks out following a surgery that was thought to be needed for, the symptoms that he had in his back and his right lower extremity. But you look at that hip, right? That hip, that range of motion findings, those range of motion findings are somewhat telling, right? So the PT in this case wound up getting an AP view of the pelvis. And we'll talk a little about, the specifics of what imaging is necessary. But an AP view of the pelvis is kind of nice because you get a bilateral comparison of both hips, right? And so when we look at this is an AP view. His left hip is actually on your right. Left hip's on your right. His right hip or his involved hip is on your left. And as you can see there, and that's the radiologist report there in figure 1, right? There's complete collapse and dissolution of the right femoral head, consistent with AVN and secondary advanced degenerative changes. And so this is a guy that was seen for symptoms that were thought to be related to his lumbar spine. Got an MRI, right? Showed a significant herniation. Treated for that, didn't get better. And now we're going back in to say, what else could possibly be causing some of these symptoms? And this is it, right? Femoral head just completely gone. And so he underwent a total hip arthroplasty. And These are kind of cool. And so these if you're not familiar with JOSPT, that's the Journal of Orthopedic and Sports Physical Therapy. It's the orthopedic section's flagship journal. It's a really, really good journal. These imaging cases, we published about two a month. So we published maybe between 20 and 24 a year. We started in 2008. I know about these cases a little more in depth because I was the editor for that feature from its inception in 2008, and then I stepped away in 2016 when the journal editor in chief stepped down as well. And so I edited and saw all these cases for 8 years, and so there were literally hundreds of them that we published. But what I thought was always neat about these cases that they were one page, 250 words with a couple of images that talk about how PT, right, utilized imaging in terms of a patient case. And so in this particular case, right, the patient did well, and 3 months later, they were able to ambulate without device, and they were able to return back to their normal daily activities at a high level. He didn't have his hip replaced, it would have never happened, right? And so, I think the big thing is when you start to think about what probably went wrong here in this particular case. And we could probably spend an awful lot of time just talking about the complexities in older individuals of this hip, lumbar, spine, differential diagnosis. It's likely that you probably have contributions from both that are causing symptoms, right? But there's probably one that's a bigger player than the other. In this particular case, it was the hip. Now, a couple of things that come to mind for me as I think about this. Number one, basic stuff like always evaluating joints above and below. And if you're a spine surgeon, right, you're going to look at the spine, right? And that's the deal. And if you're a PT, because he was treated by two different PTs prior to the surgery, if you're a PT and you think that this is a radiculopathy, right, you're going to be thinking lumbar spine. But take a moment, screen those joints above and below, especially in patients who aren't getting better. I also think that there was a lack of probably a really good neuro exam done in this particular case. So we knew the quadriceps were weak, right? But if the quadriceps were weak and it was from the L3 nerve root, right, his patellar tendon reflex should have probably been diminished as well. And he probably would have also had some sensory loss, but we don't know if that was the case. All we know is that he had this pain, right, on the medial aspect of his right knee, right, that just didn't go away. Now you'd think, well, it'd be nice if there was a kind of a pattern that moved from that lateral hip down to the medial knee, that would be the dermatome. But we don't have that in this particular case. We just know that knee was affected. And so I think screening joints above and below, doing a really, really good neuro exam, and even in this particular case, severe pathology that we see on those MRIs of lumbar spine were not necessarily the symptom generator in this particular case. Because if it was, he would have got better after the surgery, and he got nothing but worse, right? And so, again, why is knowledge of imaging necessary for PTs? I think it's also important to know that once imaging is done, we're going to see things on scans. And the question for us is, does that relate to the patient's relevant impairments? The last thing I'll bring up, because you'd say, well, how could this possibly happen? What would possibly cause that? Number one, possibly trauma. Possibly trauma if he had a history of remote severe trauma to his right hip. There's lots of things that can cause AVN as well. There's lots of different risk factors for that. But when the orthopedic surgeon, who was a spine surgeon, went back and looked at this case, because he wasn't really pleased with this, why didn't someone tell him that this hip was going on, so on and so forth. If you look back in the patient's medical records, he was diagnosed with Pert's disease as a child. And that's really AVN of the hip, but in a youngster, right? So in a teenager or an adolescent. And he had that. And the bottom line was no one knew about it. So if they would have known he had that and went back and took a look at that, right, that may have gotten picked up. And so the other thing that's important is looking back at your patient's medical records and go back as far as you possibly can and get all the information that you need, right? And so I can share these. I can share these with people. Sorry, guys. I can share these with people. And let me mention this at the end because I had a couple people write in the chat. How can they get CME or CEUs for this? So what I'm going to post at the end is a link to a Google form. I'm going to ask everybody to complete that. You can copy and paste the link and get into it. I also sent it to Krista so she can forward it out to the group as well. If you complete that, it just asks for your name, your state, and your email. If you're in Arizona or Wyoming, Krista will get that list and she'll take care of you guys. If you're from the state outside of Arizona or Wyoming, I'll send you a certificate. I had a couple questions. Well, if I'm in a state, because I can give you CEUs for New York just because of our university, New York. But if you're outside of that state, you'd probably have to contact your state to see what the process would be. And I can give you a syllabus, I can give you references, and give you anything you need for the course. If you need to go to that route. But that's how we'll do it. And so these are forms that we use when we're working with PTs who are actually going to begin to order diagnostic imaging, right? And this is just for plain film radiography X-rays, right? There's lots of different order sets that you can get, right? And a cervical spine is a really good example. So cervical spine, the basic study is going to be an AP and a lateral view. We're always going to get a minimum of at least 2 views if we're doing imaging for the first time, AP and a lateral, right? And they're usually at 90-degree angles to each other. We take a look and we try in our mind to put a 3-dimensional view together, right, by looking at those different angles. In the spine, though, because the jaw overlies the upper cervical spine, there'll also be an AP open mouth view. So the AP open mouth view, the AP cervical spine, and the lateral cervical spine, really 3 views that you get. Now those views are perfectly okay if you're just dealing with somebody who has garden variety neck pain, right? They just have neck pain. But if they have symptoms going down the arm, they have radicular type symptoms, you'll want to include the oblique views. The oblique views image the neural foramen, right? The oblique views image the neural foramen. So you can't see the nerve on an X-ray, but you can at least tell, right, what's the anatomy of that neural foramen. Is there bony encroachment, right? Is there stenosis for some reason that's related to bone, something we can see on plain film radiographs? And that's oftentimes helpful. And you may get a very well-meaning physician who says, I want to go ahead and get a 5-view series for a patient with neck pain. That's perfectly fine, but those oblique views probably are not necessary. That's the bottom line. So again, and all of this handout really outlines the different studies that you would get for patients with X-rays that you're interested in. Everything is pretty much AP views except for the wrist. The wrist, we actually do a PA view. So my camera's not working today, so I would show you otherwise. But there's going to be a film plate that we're going to talk about in a minute here. And the patient, if they had to supinate their wrist to put themselves down on the film plate for an AP view, it would be painful. So we just asked them just to go and just place their hand down, usually in a pronated position. So that's the only one really out of this that's a PA and not an AP view in orthopedics. And then the second half of this form really talks about now indications for more advanced imaging. This is a musculoskeletal themed talk, although the practice patterns are broad that this could apply to. But the bottom line, when you think about MRI, you're thinking about soft tissues. You're thinking about soft tissues. You're thinking about muscles. You're thinking about tendons. You're thinking about ligaments, cartilage, articular cartilage, menisci, labrum, that type of thing. When you think about CT, at least from an orthopedic perspective, you're thinking about bone. CT would be the gold standard to really rule out a fracture. And then nuclear medicine scans, those are bone scans. Lots of different reasons to do those. We'll show you an example here in a second, but one might be to look at early metabolic activity associated with something like a stress fracture. That's a good reason to do it. The other reason to do it would be if you were concerned about a patient who potentially had cancer that had potentially metastasized to the spine. And there's 4 or 5 cancers that have a tendency to metastasize to the spine. Breast, lung, kidney, thyroid, prostate are probably the 5. Breast, lung, thyroid, prostate, kidney are probably the 5 that will metastasize to the spine. And one of the reasons that lung cancer is a leading cause of death, a cancer death in terms of men and women, is that the typical symptoms associated with the lung cancer typically don't manifest until later, right, in the stages of cancer. But what does happen is it has a tendency to metastasize to the spine or the brain. So we may see symptoms associated with that. And that's what the initial symptoms typically are. So I'll give you a quick example here. And so this is a patient that we were seeing for low back pain and left-sided radicular type symptoms. And if you look at this AP view of the pelvis, right, you can see that on the right side, which is on your left, you can see the outline of the pelvis there. It's sharp and distinct, right? Sharp and distinct. You can see the SI joint here as well. And then this particular side here, right, you can see that there's this kind of fluffy confluence associated with the iliac crest. And you can also see that the SI joint has been affected to a certain extent as well. Now, that fluffy confluence can be related to a couple different things. Long story short, we had imaging done prior, and the radiologist thought that that was bowel gas, overlying the pelvis, which could possibly be the case. The other thing in the differentiator would be something like Paget's disease, which is kind of a little bit of a mismatch between the activity of osteoclasts and osteoblasts. The other thing that can cause that is cancer, right? That's the other thing that can cause something like that would be a metastatic cancer. And that's exactly what this gentleman had. So he had primary lung cancer that had metastasized to his spine. So how would you know the metastatic, distribution of those metastatic lesions? You could use a bone scan in that particular case. So this is a patient who had, again, primary lung cancer, but we were seeing it for what appeared to be left-sided hip pain, left-sided radicular symptoms. And so here's the bone scan. So the bone scan, you inject the patient with a radiopharmaceutical, let them hang out a bit, and that radiopharmaceutical will migrate to the areas of greatest bone metabolism, right? So those areas that light up, you may have heard that, like these are hot spots that show up on the bone scan, and you can see that left pelvis affected, right? You can also see metastatic disease up into the spine as well, even a little bit into his right side too. And then the posterior view is on your right. And so bone scan's helpful. It can help identify early fractures that might not get picked up on even something like a CT or an MRI. And it sometimes gives you a nice understanding of where these other lesions might potentially be. And so, when you come to a talk like this, you're kind of beholden to what, I think is kind of interesting. And so, one of the things that I always found interesting is that, I came from a military background where we had imaging privileges. And so I've been to Arizona, I've been to Wyoming, I've done talks for these groups who've begun to gain some traction on that. A little more than an hour and a half. Usually we do a day or two, and we talk a little more detail on some of the specifics like we were talking about. But the bottom line is that in terms of diagnostic imaging, there's real concerns associated with this, right? In terms of typically the uncritical use of it, right? And we'll talk about the overutilization, underutilization of it. This particular paper looked at the overutilization of imaging. That would be imaging that's done for no good reason, right? And we'll talk about that first bullet. The evidence base is incomplete. So what's the reasons for that, right? So people don't know, where do I find the guidelines to determine if imaging is needed? Physicians in this particular case, right, we know that there are rules out there that help us determine when imaging is indicated. Many times, right, physicians bypass that because they're concerned over litigation, right? And then it's also related to content in med school, right? So there's about a third of medical schools that have very, very limited, like a day or less in terms of musculoskeletal care, right? Very, very limited, focusing on other things that's just not their focus. And so in terms of musculoskeletal medicine, the content is really quite limited in those regards. And so this is a nice, these systematic reviews and meta-analyses. So these are studies that are done that take a look at all the work that's been done out there, and then they analyze that data in a pool, and then they come up with results based upon the findings from these particular studies. So this is just looking at low back pain, right? Low back pain. That last study, or that last paper I just talked about overutilization of imaging. And then here's the results here. So that first red circle really speaks to overutilization. So if you look at patients who are being imaged for low back pain, this is MRI, right? About a third of them did not need the scans based upon their history and physical exam, right? So a third didn't need it. That's the overutilization. And what struck me here is the second number, that's underutilization. So in this particular case, these are patients who needed imaging, right? So they had red flag findings that warranted diagnostic imaging, and it wasn't done in 2/3 of the cases. So now we not only have overutilization, but really have an underutilization. So going back, to this uncritical use of diagnostic imaging, it truly is the case. And we'll comment a little bit more on that in a minute here. So, let's go ahead and have a little bit of fun here. I'm always faulted by not having interactive activities here. So let's talk about this particular case. So go ahead and read this case, and then we're going to ask you what your next step would be in this patient's management. And if you're the daring type, the guys and gals who go out on the dance floor on New Year's Eve and, party it up like that. I'm not a dancer, so I'm kind of the shy type. You may want to provide some feedback in the chat. We'll talk about it. But she's 55. She was in a motor vehicle collision, rear-ended by a car going 35 miles per hour. She had pain later that day on the right side of her neck, as well as a headache. No paresthesias. Pain's 5 out of 10. Difficulty sleeping. Unable to go to work. Right. So this is a day later. Active neck rotations, painful to 50 degrees both ways. Left neck rotation. I'm sorry. Right is 50. Left neck rotations full. Active neck extensions, painful to 30. No other health issues. She's seeing you in a direct access capacity. And what would be your next step? So these are your choices. One would be a CT, two would be an MRI, three would be an X-ray, and four would be no imaging is necessary, and you would proceed with PT management. Anybody want to? I'll close the share, crack open the chat room, and see what we got. 3. Very good for playing. X-ray. Tyler's going to get an X-ray. X-ray. Mary says no imaging. Bob says no imaging. Zach says no imaging. Hello, Zach. X-ray. Canadian C-spine rules say plain films. X-ray. Yeah, Canadian C-spine rules. No imaging. Oh, we got a little controversy here. A little controversy, which I like. Little controversy. Little controversy on a Wednesday night. X-ray and PT. A snowy Wednesday night here in Buffalo. If anybody watched the game, it's just the same little storm that's been monkeying around with us it's been around for like a week. Got up above freezing, stuff melted. Now it's all frozen with this little bit of snow on top. X-ray followed by MRI. You're throwing it all at him, Bob. You're going full bore. Bob says, I ain't playing any games. Double barrel. X-ray followed by MRI. Okey doke. We'll talk about that one in a second. Very good. Thank you all for participating. That's outstanding. That's absolutely outstanding. So I have to go back in. That's good. That's little interactive activity there. Let me go back to this here. Oh, here. Go back to sharing again. Sharing is caring. That's what they tell me. So we'll talk about the answer for that one here in a second. And then we'll go and we'll do case 2. Case 2. Case 2. Healthy male, aged 67, fell off a ladder 2 days ago. Immediate pain in his neck, more so on the left. 6 out of 10 pain. He has symptoms into his left forearm, and he has some intermittent tingling in his left thumb. No dizziness or headache. Sharp pain with left cervical rotation makes it difficult for him to drive. Unable to tolerate sitting since the accident. He's been to a walk-in clinic, like a urgent care, and the PA gave them Tylenol and took him off work for a week. He works in a convenience store. He now refers himself to your clinic. What would be your next step in his management? So neck pain following a fall off a ladder, 6 out of 10 pain, no dizziness or headache, sharp pain with left cervical rotation. So let's take a look at this. So one would be a CT, two would be an MRI, three would be X-ray, and four would be no imaging. And you're going to proceed with your management. First person was seen. Our first person was direct access. This particular patient was now seen by an urgent care provider, but then seeing you. Let's take a look what we got here for this one. All right. Can she rotate both ways? Limited both ways. And we didn't give you any range of motion there, Joseph. We didn't give you a number. X-ray, PT eval. Bob's going to get some imaging. Catherine's getting imaging. Very good. CT for Linda. Mary's getting 3. X-ray. Yeah, 2, 3, CT, MRI. Further assessment needed. John, I'm guessing you mean with maybe diagnostic imaging? Yeah, active range of motion. We want to know the number. Yeah, he would be less than 45. Yeah, we didn't throw that in there. We didn't put that in there. So these were as part of what we do, at least at the university I'm at. Our students have to do a research project. So I teach in an entry level PT program. So our students do research. This was a study that we just completed, and we actually just presented at our research symposium on Saturday. It's been accepted for CSM, hasn't been published yet, but these were cases that were developed by a Canadian group of physiotherapists. And we took their 2 cases. We had permission from them to use these 2 cases. We sent it to the APTA. If you give them $200, they'll do a one-time email blast to all their members. So maybe some of you, if you're members of the APTA, might have saw the survey back in June, way back in June, right? And so we looked at these 2 cases, and I'll go back to them and we'll talk about them a little bit because I think it's good because we had some interesting answers that kind of make some of the points that we're talking about, right? And so if we look at, somebody mentioned the Canadian cervical spine rule, right? This is it, right? This is the Canadian cervical spine rule right here. And so the Canadian cervical spine rule says that, right, if you're somebody who's older, over 65, with a dangerous mechanism, and we could talk about what those are, but that would relate to things like a high-speed motor vehicle collision. If you fall from a height probably more than 3 or 4 feet, which would be more than like a meter or 2, right? If you're talking Canadian, right? And you hit something, there's a chance you're going to probably break something, right? Or if there's paresthesias. Now, these rules are designed to be extremely pragmatic and used by emergency room physicians who are making point of care decisions kind of on the fly. So again, if they're older, dangerous mechanism or paresthesia. And I want to say the dangerous mechanism was being in a motor vehicle collision more than 50 miles per hour. So if we think about that second gentleman, right, he's over 65, but he fell off a ladder, right? Fell off a ladder and hit his head. That's probably enough at that point to say that he needs radiography, right? He needs imaging at this particular point. And then if none of that's present, and that would be in the second case, right? So a lower speed motor vehicle collision, right? She's younger than 65 and she doesn't have paresthesias, in her upper extremities. Then you start to look at these low risk factors that suggest that I can evaluate range of motion, right? And as PTs, right, we sometimes want to move the neck, right? But if you're concerned about a fracture, you really don't want to do that, right? You don't want to do that. So if it's a lower speed MVC motor vehicle collision, they've been sitting at any time, they've been ambulatory, there's a delayed onset of pain, meaning my injury was 2 days ago, it started today, right? That's typically not fracture quality. And then absence of midline cervical spine tear. So you can palpate, and you're looking for fracture quality pain. And people say, well, what is that? If you've never broken a bone and had someone stick a finger in that fracture, you wouldn't know what that is, right? But if you've broken a bone and you touched it and palpated it, you know what that is. And it's typically pain that's probably around that 8, 9, or 10 level, right? So the first patient really didn't have, right, any of the findings in that top box. She's younger. What does that mean? Because the older you get, the greater risk you are for metabolic bone disease, things like osteopenia, osteoporosis, easier to break a bone. Didn't have a dangerous mechanism, no paresthesia. She's been up and around since that time, right? And so if you have one of those and you rotate her neck, she can turn her neck to 45 degrees both ways. So she did not need imaging. The second patient did, right? Just because they're older with a dangerous mechanism. And then the question comes up, well, what imaging should I get, right? What imaging should I get? Because when this paper was published, right, they said radiography, right? So this is from JAMA way back in 2001, probably before some of you were even born, right? But they said do x-rays, right? Do x-rays at that particular time. Well, these rules are designed to be what we call sensitive, meaning that if I get right to this bottom here, like if I'm talking about that first patient, I get here and I get to the point where I do not need radiography, I can be 100% confident that this patient does not have a fracture, and now I can proceed with my conservative management. However, they're not designed to be specific, meaning that if it's positive, it doesn't rule a fracture in. It says you need to get some type of imaging, but it doesn't tell you that there's a fracture present, right? So they're about 50% specific, meaning about half the time if a patient meets the Canadian cervical spine rule, they won't have a fracture, probably even a little bit more than that. But they're designed to be very, very sensitive. And you'd say, well, that's interesting because there's a Canadian cervical spine rule. There's not a Buffalo cervical spine rule. There's not a Phoenix cervical spine rule because Canadian, right, the Canadian medical system is a socialized system paid for by the government. So if they can eliminate, right, overutilization of imaging through a validated rule, right, you can eliminate x-rays in lots of cases, right? And an x-ray, what are you talking? $100 maybe? No big deal, right? But you start doing thousands, thousands, and thousands of these things, you get yourself into a jam. The other thing is, anytime you do imaging, you're always going to find stuff. You're always going to find stuff. These are probably false positive findings that lead you down a path that you continue to have to work on, right? And so, no radiography. The other thing that I'd say is that, the gold standard for diagnostic imaging right now is the ACR appropriateness criteria. So I'll go back to these two cases before I say this. So case one here, we had about half of the PTs who did this study say they would get imaging when it wasn't probably indicated. And then this particular case here, we had about 80% of PTs saying imaging was necessary. About 20% of patients or PTs said they wouldn't get imaging. But case two, imaging was indicated. Case one, imaging was not. And then the question kind of comes up, well, what type of imaging would you get? And the ACR appropriateness criteria is great because that really helps a lot in helping folks to think about that. So in that study I just talked about 90% of PTs said they heard of the Canadian cervical spine rule. But the last question we said, have you heard of the American College of Radiology's appropriateness criteria? Only about 20% had. And really, this is the gold standard. So what I'm going to do is, and what they are really evidence-based guidelines that really help imaging in pretty much any domain. So you're talking breast, cardiac, GI, UG, nervous system, musculoskeletal, interventional radiology, etc. And so, and it continues to grow. In fact, it just changed, like as of today. I'm going to back out of this for a second because I was looking at this and I was kind of taken aback. And I'm going to follow up on this right here. That when this thing came out, it said in 2001, radiographs would be the test that you would get. And there's probably a couple of reasons for that. I'm treating a retired radiologist right now. Very interesting to hear, but back in 2001, MRIs and CTs were not that prevalent. Go back 10 years earlier, like the early 90s, you didn't have a lot of places that had both, right? So X-ray might have been your only choice for that. But things are different now. So I'm going to back out of this and I'm going to pull up the Canadian cervical. Not the Canadian cervical spine rule. I'm going to pull up the. The American College of Radiology's appropriateness criteria. And so if you go into this, I'm going to pull this up here and see if you guys can see this website here. So this is what it looks like, right? So this is, I'm into the portal. And so if you don't even need to log into it. You just Google it and you can pull it up. The screen will say, click to get in. And you can see here, right? These are all the different variants that you'll potentially see. And you're going to get the phone book, right? Because like I said, it starts all the way up here, breast, cardiac, GI, OBGYN, radial, interventional, MSK, all the way down, right? So you have to find the right variant that you're looking for, right? And so you'd go in here, right? You go in here and you're looking for cervical spine pain, right? So this is all ankle stuff here. And then where's the cervical stuff here? And so this is kind of real time here. You're looking for the cervical spine trauma, acute, imaging indicated by the CCR. So they're assuming that you know the Canadian cervical spine rule. They're assuming that you know what that is, right? But even you go up one here, right? Cervical spine trauma. Remember I mentioned about that 3 feet or 5 stairs? Anything more than 3 feet trauma, think about a shoulder, think about an elbow, especially in older folks, you got to be concerned about that. So if you click on this button here, if you click on this one here, you're going to get all kinds of good stuff here. And you want to look at the narrative table, right? The narrative table. Do folks see this? If someone could just unmic themselves and see if they can see this variant 1. Can someone see? Can you guys see that? Allison, I think you're unmuted if you're out there.
Yes, we can see it.
Perfect.
Yes.
And so these are the different variants, right? These are the different variants. And I do have a point with everything I'm talking about here. Trust me, I'm trying to get to it. So the first variant, right? Trauma, but imaging not indicated, right? So they list out the phone book for the procedures. None of them are appropriate because they don't meet the rule. Nexus is another clinical rule that you can use, very, very similar to the Canadian cervical spine rule. If we go down here, this is the second one. Older individuals over 16, right? Acute trauma, imaging indicated by the CCR. This literally just changed as of like a week ago, right? So they now say that the only appropriate test is a CT, right? So look at this. MRI, radiography are not indicated, not appropriate. And so you'll say, well, why would that possibly be? Think about this now. What we said at the beginning. What's the best test to rule out a fracture? CT scan. That is the number one test to rule out a fracture. I'll talk about MRI in a second, but why don't they recommend radiography? I talked about those principles of sensitivity and specificity for a Canadian cervical spine rule. And if you're old like me, we didn't talk about that stuff, but it relates to diagnostic accuracy in a test and the confidence you can have in it. And I mentioned that Canadian cervical spine rule is sensitive, meaning if it's negative, right, they're not older, no paresthesias, no trauma, they've been up and around, they don't have fracture quality pain tolerance, and they can move their neck more than 45 degrees, they don't have a fracture. You do not need imaging. It's not specific though, right? Because even if they meet the rule, you do imaging, you're probably not going to find a fracture, probably like 75% of the time. But CT is highly sensitive and highly specific, meaning that if it's negative, you can rule something out. And if it's positive, you can rule something in. X-ray, think about that, X-rays. And if these were students in the room, we'd talk about this, right? Are they sensitive or specific, right? X-rays are specific, meaning that if you see a fracture, right, you see a fracture in the dens, or you see a fracture, like in the pars, you see this hangman's fracture, it's there. You're not going to argue it, but they're not sensitive though. X-rays are used as screening tools all the time, and they're negative. And if you read the radiologist report, especially with trauma, what do they say? If the patient still has symptoms, re-image 7 to 10 days later. Now, you can do that for an ankle. You can do that for a knee. But I'm going to tell you right now, you do not want to do that for the C-spine. Because the C-spine, now you get yourself into a jam, right? And I found out about this because the students who were doing this research did a really, really nice job of finding papers. But they wound up finding papers from like the 70s and 80s. And the number of patients that were dying, right, from these cervical spine traumas where they got x-rays, the x-rays said they're normal, right, but they didn't move on to the next imaging. So they don't recommend x-rays because even if you get the x-ray and it's normal, you still can't rule out a fracture. And so we'll go down here. Why would you get MRI? Right, so if they had neurologic symptoms, right, so if they had neurologic symptoms, so right here. So if this was a patient, right, and we had neurologic symptoms or symptoms associated with what we thought might be ligamentous instability or the spinal cord, MRI would be the study to go to. We said that before. Soft tissue, right? Brain, spinal cord, nerves, cartilage, muscle, tendon. ligaments. That's what MRI is really, really good for. It can be used for bone, but CT is still better for bone. I'm going to admit Dustin, who's in the room here. All right. Any questions on that? There's a lot to that we just talked about, but these are the gold standard now for diagnostic imaging, and they're great because they give you these variant tables, and you can work your way all the way down, and then they give you really, really good information with all the references and everything, and they update this thing all the time, right? But this is really the gold standard right now for diagnostic imaging. So I'm going to stop sharing that. Nice picture of Bob right there on my screen. Excellent. All right, so let me share again. Go back to sharing. Any questions on anything at all? Questions on anything? Very good. All right. So for those of you that, looked at that case one and case two, and case one, you thought imaging might be needed. Hopefully that helps a little bit and tell you why it probably isn't indicated. For case two, majority of you said they would get imaging, but the question comes up, what imaging do you get too, right? And that's always interesting. And so let's switch gears a bit. Like I said, I was putting this talk together today. I know some folks are in here that have heard me talk before, and I sometimes switch these things up a little bit. But right now, there's a strong, and you guys know this, Arizona, Wyoming for sure. You guys know there's a strong push for some states to get diagnostic imaging, right? States to get diagnostic imaging. And and I think this is the most current map that I have. So last talk I gave to a fellowship group probably back late summer. I got this graph probably probably mid-August. So maybe it's changed a little bit. But the bottom line is the states in green have some type of imaging, right? Have some type of imaging at some point. And, I've been fortunate enough to talk in a lot of these states. So North Dakota, Iowa, Arizona, Utah, Nevada, Wyoming, Colorado, because there's a push, right? There's a groundswell, right? That you have to have in order for PTs to get imaging. And you'd say, well, is it really that big a deal, right? So when Iowa was trying to get imaging, this a couple of years ago, right? So I just talked about the American College of Radiology appropriateness criteria. Now you would think they would like us, PTs, right? Compassionate, empathetic, easygoing, right? We take good care of their patients, right? And you take a look at this letter from the American College of Radiology. This is from the president, right? The chief executive officer, Dr. Thorworth, right? He's the big dog. And look at that highlight, right? What we have highlighted there. This is when Iowa was trying to get imaging. They wrote a letter to the committee members who are going to be voting on this, right? And they are in absolute opposition of PTs getting diagnostic imaging. Now, why do you think they would oppose it? Just think about it. Anyone want to unmute and just yell out what you think? We just gave them a huge shout out, like I'm getting paid, like an endorsement to endorse the ACR, and I'm not.
Fear that we're going to take their business away.
Take their business away, huh? That's an argument for another day. That would be the California orthopedic surgeons, right, to direct access, right? Because we're going to take their business. Yeah, I think you're onto something there. But let me show you the next one, what they say. And look, we just talked about a meta-analysis that said that there are huge over and underutilization issues. The paper before that was published by a radiologist and a health physicist in the New England Journal of Medicine that said there is true uncritical use, and they gave you the reasons why. So up on top, they talk about it here, right? So they're opposed to expanding the scope, right? Because their concern is that all this is going to do is continue to burden an already overstressed system. And then these repeat exams are going to potentially expose these patients to unnecessary radiation. And that's legit. That's legit. I won't go back to that American College of Radiology appropriateness criteria site, but on the far right-hand side of those tables, it gives you the amount of radiation that's associated with those tests, right? X-ray, not so much. CT, a little bit more. MRI, none, by the way, right? And I haven't talked at all about point-of-care ultrasound, but point-of-care ultrasound is great for imaging soft tissues, right? Superficial soft tissues, things like that. But they cited in that second paragraph they cited a study that, and I went back and reviewed these. Very interesting. So there's a group out there that is hell bent on getting what they call these advanced clinical practitioners. So you think, what would an advanced clinical practitioner be? They call them ACPs. It's essentially nurse practitioners and PAs. That's what they call them, ACPs. And there's a little group out there that is hell bent on trying to figure out what the imaging tendencies are of this group. And they did show that, PAs and nurses tend to utilize imaging when not indicated a little more than physicians would. And the second study is another group, right? They found that in 34% of these emergency department cases, PAs and nurses would recommend imaging when physicians would not. Okay. So that was their rationale for why that is. And so how would you fight that? Right? I showed you the data. Some of you over-imaged the first case, right? You overutilized it. So how would you fight that type of thing? Right? Well, number one, to compare us to PAs and nurses, right? That was the first argument, that we're not PAs and nurses. We're trained at a doctoral level with extensive training in musculoskeletal care, right? That was the first argument. The second argument is that, and this paper just came out in August 25, but there's others like it. So this is looking at these trends that we see in first contact PT practice, because that's what this related to here, right? So these advanced clinical practitioners, nurse practitioners, and PAs, they're camped out in emergency departments, they're camped out in urgent cares, right? In fact, I'm working with, have you seen, these little, I don't know what they call them, like well nows and things like that? They're popping up all over the place, right? But we're working with a group of 5 of them to try and look at, some of these tendencies in terms of medication prescription, what type of ICD-10 codes they're seeing, et cetera, in terms of musculoskeletal care. And there's a group of them, there's 5 of them, and there's one physician that works among all 5 groups. All the rest are either nurse practitioners or PA. I'm not saying it's good or bad, but that's the reality of it. So this first contact PT practice, right? Systematic review and meta-analysis just published in 2025. If anybody wants the slides, let me know and I'll email them to you. I'll get them to you. But that YouTube video down there is a nice interview with a little podcast with these authors who do a really nice job of talking about this. And what do you think it showed? Okay. What do you think it showed? We've known this for a long time. So if you let PTs do these type of things, right? So you're talking about military PTs, and now even groups, states that are allowing physical therapists to do imaging. What do we note? Well, number one, we know that there's significantly less imaging on the part of PTs. Significant, so it's less imaging. This is the bottom line: less imaging, less medications, right? Better outcomes, lower cost. That's the bottom line. Less imaging, less meds, better outcomes, lower cost. In the imaging and the meds, right, we could talk about why that is, right? We don't train our PTs to rely on diagnostic imaging. Nurse practitioners and PAs, that's part of their training, right? We don't do that though. They get instruction diagnostic imaging, but their ability to take a sound history and do a good sound physical exam, right? And then look at response to intervention. You think about this hypothetical deductive reasoning model to develop hypotheses and determine if they're supported or refuted. That's how they're trained, right? We don't rely on imaging. We don't rely on meds, right? And we don't think that way. So these tendencies are completely 100% legit. Now you'd say, well, that's from 2025. This stuff must be pretty current. So as I'm hunting around, right? This paper was from 1998. 1998. And what do you think they said, Bob? They said the exact same thing in 1998. I think I was a senior in high school thinking about that. Same thing in 1998. And why did they know it in 1998? Because they had probably about a good 15 to 20 years of sound, anecdotal, and even some data, better data from the military PTs. It was late in the Vietnam War when those military PTs started to get, this first contact practice type of a setting where they said these musculoskeletal patients, physicians aren't well trained to treat them. Let's go ahead and let PTs deal with it, right? So they gave them imaging, right? They gave them a limited formulary. They allowed them to send them to a primary or a specialist physician, et cetera. And so, but this has been around a long time. I'm not saying anything you don't already know. I'm going to go through this stuff pretty quick, but the bottom line here is that, we know that back and neck pain and other musculoskeletal disorders are really, really significant in terms of morbidity and not necessarily mortality, but in terms of morbidity and the disability, associated with it. I show this a lot, and students kind of make fun of me, but I think it really makes good sense to me. Because when you start looking at these global burden disease studies that are done by really smart people, looking at data over the course of 25 years, you start to think about back and neck pain being the number one cause of disability worldwide, followed by things like depression and some of these other concerns, right? And you look at the colors, right? Green on this graph means that patients are doing better. Yellow means it didn't change, and red or orange means it's gotten worse over 25 years. So when was the last time you went to a talk by someone who's supposed to be like me, knows what I'm talking about, and tells you we have no idea what we're doing with these patient populations? Because everything is red. Everything is orange or red, meaning that over 25 years, back and neck pain outcomes have gotten worse. Diabetes outcomes have gotten worse, depression outcomes, other MSK, right? Osteoarthritis, everything has gotten worse in terms of outcomes. And the cost associated with these, you say, how much is all this, right? Musculoskeletal disorders have now overtaken non-communicable diseases en masse, like cardiovascular disorders, cancers, and diabetes. It's overtaken that in terms of cost. So the cost associated with this is astronomical. And you'd say, well, of that $380 billion spent on musculoskeletal care, what's that from PT? I'd say probably you look, between 2 to 5%. Not much at all, hardly nothing, right? So you'd say, well, what's causing all that? And I'm going to get off this track here in a second, but if you get nothing more out of this tonight, just understand the significance of this problem, because it is a real issue, right? And we think about now guideline discordant care, right? What does that mean? We know there are clinical practice guidelines that should help us understand what the best way to manage patients are. We know that. It's there for low back pain. So we know that, if you're dealing with a patient with acute low back pain, self-care advice and education, the use of nonsteroidals or acetaminophen, not opioids, and then PT, right? We can get into what that PT should probably look like, right? And there's some arguments for what that might be, but that's it, right? That's the guidelines associated with this. And what do we see, right, over the years? I'll show you that slide here in a second. What we see is that the referrals to PT have actually gone down, and the referrals to specialty physicians have actually gone up. Now, this is acute low back pain that's mechanical in nature and non-specific. What do I mean by that? This is not cancer. These are not fractures. This is not cauda equina, right? This is not infection. This is not some type of rheumatologic disorder. This is just your garden variety low back pain. That's not sinister in nature, right? So why are they sending them to specialty physicians? Why are they not sending you guys, right? Opioids continue to be a problem here, and you start to see less and less of acetaminophen, nonsteroidals being used. And the big thing is imaging. Imaging has just exploded, right? And systematic review here, the most current systematic review, again, just kind of highlights what we spoke about. And so, going back to this again, and I would ask you, if you're working in a big hospital, right? Big hospital, we just did this. So, Catholic Health is the big one in Buffalo that we affiliate with and we like to work with. There's probably like 10, there's 10 in Buffalo, 10 or 12 centers in Buffalo. And we look at, these ICD-10 codes that relate to low back pain, and we find out how many of these folks actually saw PT. And what would you say and this is nothing new. What would you say the percent of patients with low back pain that enter into a medical system actually get to see a PT? I'm going to stop sharing. And I'm going to ask you guys to put that number in the chat in terms of a percent. A percent. They don't trust our judgment. Mary, you're so right. Bob's right. 10%. 30.
Yeah.
Yeah, Bob, you're right. It's around 5 to 10%. And these are good centers, right? So I use the example of Intermountain Healthcare, right, in Utah. Good hospital group. Great hospital group, right? I know the ones in Utah, right? But they've published that data, right? You're talking 5 to 10% of these folks seeing PTs who are really the experts in that, right? And it goes completely opposed to all of the guidelines, all the evidence-based care. I just showed it to you. Data over 25 years that we can't get these folks better with the methods that we're using. And we'll talk about why that is here a little bit more detail, because I still got like another 20 minutes to be able to talk here. And so let's get into a little bit here, of some of the specifics here. And so, and I just, the AOP meeting was recently in Reno, Nevada. That's always a nice place to go and hear the American Academy of Orthopedic PTs who are really kind of on the forefront of recommending sound conservative manual therapy and therapeutic exercise-based care. And they come out with these infograms here, and they're always very interesting. And so, reframing these MRI abnormalities as part of the normal aging process. And, I just evaluated a patient yesterday, and I'm seeing her for some knee pain, some hip pain, and she said, yeah, doctor told me I have, degenerative changes in my knee. He said, it's basically bone on bone. There's nothing anybody can do about it. Either I get injections or I'm gonna have to get a total joint. You just set those folks up to almost feel like that's the only option that they have, right? She's 65, right? Yeah, she has some changes on her radiographs, but those are the type of patients that you kind of do a really, really good exam, and you go ahead and you give them a little bit of the Cadillac treatment from a manual therapy perspective. So when they get up off that table and they squat or do a lateral step up or they walk a little bit, how's that knee feel now? Wow. All of a sudden, my knee feels a bit better. We'll pop back up. We'll see what we can do for your hip. Wow, my hip's feeling better. I can move my hip a little bit better now. So maybe this PT stuff might work. Heck yeah, it could work. Big trial just published in the New England Journal of Medicine, right? Looking at these folks with these old degenerative meniscal tears and OA of the knee, right? Compared PT to surgeries to injections, and PT didn't even compete, right? Didn't even compete. PT, I thought, I'm not going to say it, but I didn't think the PT was really, it was kind of, here's some exercises and you can do them at home or do them in the clinic. It really didn't work out very well. But bottom line here is that when you think about these patients who have that mindset, that, I have this degeneration, I have this bone on bone, whatever, it automatically sets them up to think that whatever you're going to do isn't going to work. And we're seeing huge trends of patients who just stop coming to PT, right? Just stop coming, right? Because it just isn't working for them. And there's reasons for that, but reframing all that. So remember the overutilization stuff we talked about. This is people like over 40, with no pain. If you start doing MRIs of the spine, you're going to see a ton of findings. You're going to see stuff at the shoulder, the knee, and the hip. And the bottom line is you get nothing else out of this, at least from today. Think about how you talk to these patients in terms of their imaging findings. Now, you got to be careful because they probably talked to a physician or a PA or a nurse practitioner who's told them something, right? These are degenerative findings, and they're not going to get better. And that's what's causing your symptoms. Well, who would think, right? If I had my slide on right now, you see a white beard, pudgy belly, out of shape, wrinkles. I mean, why would you think me at my age, almost 60 years old, that if you did an MRI of my neck or my back, that it should be pristine and normal? It's never going to happen. It's never going to happen. This is normal aging, right? These are normal anatomic changes, right? And we've never thought about that before, right? So when we start talking to patients in that context, now you got to be careful, right? Because you're making a call based upon your history and physical exam that those imaging findings are truly that. And they may not be a symptom generator, but think about that when you start talking to patients. And we try and also think about what are some of the better ways of managing patients. And the back book was a wonderful book that's been out a long, long time, and it's really used for patients who have kind of fear avoidant behavior, right? But those imaging findings, we start to talk to them that it's very rarely a sign of significant disease, commonly found in patients without low back pain, right? And the implications, right? Just because you have those changes and even the back pain doesn't mean there's permanent damage, right? And so you get the message that we're trying to portray there. And if you think about this was a study that looked at, kind of a fear avoidant approach versus kind of this biomedical approach, and, on the left, you can see what some of those trends are. You have changes on your imaging, there's not a lot we can do with them, and you should avoid activity when you're having pain, right? Let's think about surgery, injections down the road, right? Versus the right side, again, just because you have those changes, it doesn't necessarily mean there's serious damage, right? That can't be dealt with, right? doesn't mean that, right? And so it's a different way of framing the education associated with those imaging findings. And again, diagnostic imaging, small component of this overall exam that we're doing. It's a data point, right? Sometimes it means a little more, a little bit less, depending upon the patient, right? And that first patient we talked about with the AVN in his hip, it's a huge data point, right? It's going to drive the course of care. It's going to drive, but normally it's kind of in the mix of all this stuff, right? So we start talking about, these type of studies here, you start to find stuff, you're not sure if it's significant or not. That's when you really have to think, let me put this in the appropriate context for this particular patient. Last thing I'll talk about before we move on to a little bit of imaging here. Interesting study here. So these are patients who had chronic low back pain who were getting MRIs. And they looked at 4 different domains. They looked at pain, they looked at catastrophizing behavior, then they looked at physical and emotional well-being. And one group, and I just reviewed this study before I came on, so I'm able to make sure I understand the bones of this. The one group got usual care in terms of MRI education. You have degenerative disc disease, you got a herniated disc, it's pressing on a nerve, that's the cause of your symptoms. So it's basically whatever the radiologist said, we're just giving it to you. That happens all the time. Versus an approach that said, this is probably more, right? Just anatomical gray hair, right? This is probably the normal aging process that we're seeing on these scans, right? And everything else was the same between the two groups. But all these findings 6 weeks later, pain significantly different. Catastrophizing, right? The higher the graph in the orange, the higher the bar in the orange, the less catastrophizing, right? But orange is the group that got the well-informed education. Pain went down, catastrophizing improved, and their physical and emotional well-being both improved, right? Just with that educational approach that we just talked about. So if nothing more, think about that 5 minutes that you have to spend with the patient to help them really understand kind of what's going on there. A couple other things I just want to mention that'll maybe lead into some future talks for you guys. But we did this survey, and it really drives some of the stuff we're talking about today, right? We're talking there. So we had 5,000 PTs who took close to 5,000 PTs who took the survey. What we wanted to know was, are PTs doing the requisite skills that are needed for diagnostic imaging, even if you can't order it, right? And you can look at that green box there. So they're triaging the patients, they're using evidence-based guidelines, etc. All those things down. We looked at the numbers. And all we asked was, are you routinely doing this? Are you rarely doing it or never doing it? Okay. And there were really, really good findings. So when these infograms kind of come out, through these different this was through AMPT, the American Academy of Orthopedic Manual Physical Therapy, who jumped on this and they said, this is really, really great. And we need to make sure that we get the message out. So the lead author, Lance, did a bunch of podcasts, and he, went on the morning news and started talking about all this, how wonderful PTs are, which is, 90% accurate based upon these data. But when you dig in a little bit deeper, there are 2 skills that the PTs did not feel all that comfortable with. And it was skill number 2 and skill number 5. And goes back to what we talked about. Skill number 2 is using evidence-based guidelines, and skill number 5 is suggesting an imaging modality. And even if you suggest x-rays, what views would you get, right? Because we just talked about that could be complicated. What views would you get, right? So those are the 2 that when we do these type of talks, that's why I'm so passionate about it, because if I can just get somebody to know that Canadian cervical spine rule, might not have known it previously, or maybe take a glance at those American College of Radiology appropriateness criteria, that's good. Like I said, we talked a little bit about that skill 5. What imaging modality is best? When's MRI needed, right? When's CT needed? When's plain film needed? When's a bone scan needed? When is ultrasound okay? Because lots of PTs are doing point-of-care ultrasound. When's that indicated, right? And we talked about this earlier, this first contact PT practice. It's helpful, and it's been around a long time. But when you start to use this first contact practice, you eliminate all the middlemen and middle women, I guess, right? You eliminate all that physician stuff, the imaging, the referral to specialists, etc., right? You decrease cost, and all kinds of really, really good things happen. Waiting time to get to a PT decreases. MRI, we already talked about this. MRI utilization goes down. Cost goes down. Outcomes improve. Pain improves. No meds, or very, very few meds. Work loss, all that stuff improves. And so there's really, really good evidence for that. And we talked about that with this particular trial here. And so I'm going to end on this particular case. I said I would stop at 10:02. 10 minutes to. So I got 7 minutes to go through this. Yeah, so we'll go ahead and do this one. Some of you, if you've heard me talk before, this is a case that I like to talk about that kind of hammers home some of the things we talked about. So in 7 minutes here. So this is a woman that's coming to see a PT. This is a patient being seen in Australia who was going to see a PT. She's pregnant, and she just wanted to know if her low back pain is going to get worse as she works through her last trimester. Right, so she complains of this intermittent ache in her low back. That's typically standing for long periods of time. If she vacuums or she prepares a meal or she does dishes or she even goes for a walk, her back starts to hurt. But then she sits down and kind of goes away. Right, 22 weeks pregnant, and she was diagnosed. She tells the PT, I was diagnosed with a spondylolisthesis at age 18. Right, so she was diagnosed at age 18 with a spondylolisthesis. So she fell out of a tree when she was 11 years old. She had pain all through her teenage and adolescent years, finally was imaged at 18 and was told that, you have this, this slippage in your back. But the funny thing is that up until she was pregnant, she had no back pain for the last 7 years, right? So from 25 to 32, no back pain. Now my back pain's coming on a little bit. Is there anything I can do about it? Is it going to get worse? If it's going to get worse, what can I do? Clinical exam, totally normal. So normal neuro exam, and we talk normal neuro exam, we're saying good reflexes at the Achilles, patellar tendon, L2 to S1 myotomes, L2 to S1 dermatomes, everything good. And she's coming in today. She's sitting in the waiting room. She's sitting fine. Normal range of motion, no problem. And I would ask what the next step would be, right? What would the next step be? And having presented this case to so many different PTs and groups, I'll get, we'd educate her on posture. We might provide some stabilization exercises for her. We might talk to her about how she can maybe mitigate some of those symptoms when she's standing for long periods of time, because her back pain's going to probably get worse, right? Her back pain's probably going to get worse as the pregnancy progresses, and that's normal, right? But there are certainly things we can do as PTs to do it. This physical therapist, though, said, we're going to do all that, but I wanted to ask you a couple other questions. Have you told anybody else about the spondylolisthesis? And she said, I'm not sure what you mean. So her obstetrician was going to be delivering the baby, right? So she had a good relationship with that individual. So she hadn't told the OB physician. And she had also already counseled with the hospital's pain management department. She was going to have an epidural, right? And did you tell them anything at all? No, we didn't. I never really mentioned it because no one asked me. So the OB doesn't know. The pain management staff doesn't know. And now in the military, right, we're training PTs on how to do, some of these PTs are now doing injections, right? And what we teach, and even dry needling too, anytime you're sticking a needle into something, if not a contraindication, but a sound precaution would be abnormal anatomy. Because, we train people based upon normal anatomy. So if there's abnormal anatomy, you sticking a needle in there would probably be a strong precaution, if not a contraindication. So this PT reaches out, talks to the obstetrician, who basically says, I don't know anything about this. Does the pain management staff know? They say no, right? And, so, well, what can we do to see this back? She's pregnant. Can't do ionizing radiation, so CT and MRI are out. Would ultrasound show it? Probably not, right? You can't get deep enough with that transducer. What about an MRI? Yes. And is MRI safe in women who are pregnant? We think so, right? No ionizing radiation. So here's her MRI. Anyways, they want to get a look at this before they think about how they're going to go forward here. So I'll put a normal study up on the right? These are sagittal view, T2 weighted MRIs. All that means is that fluid shows up bright. And on the right, normal, you can see those vertebral bodies stacked up nice, like in a nice column. And then you look at her scan on the left, significant, right, like a grade 4, L5 on S1. And if you look back here, the nerve roots are kind of tethered back there, right? And you got hard compression between the posterior elements of L5 and the sacrum, right? So those nerve roots are being compressed. How does she not have cauda equina, right? And so the question comes up, well, what do you do about this, right? And so that nerve, right, or that needle is going to probably go through about L1, L2. That's going to provide that area of essentially anesthesia, right, from the, from the belly button up, a little higher above the belly button down, so that, they can have, moderate pain relief, right, during delivery, right? And so the radiologist or the intervention or the pain management physician said that there's no way that they're going to do this. There's no way they're going to do it. The OB physician said, I would agree, because of the proximity of those nerve roots, right? So the spinal cord terminates right around L1, and then it turns into those nerve roots, the cauda equina. And the risk, right, of, sticking a needle in somebody's back, right, is that you could potentially damage a nerve, right? Damage a nerve. And so they decided they weren't going to do that. So this is a case that was published in those JOSPT cases. And again, I wouldn't know the whole backstory unless I was working with some of these authors, because the editor in chief was really, he said, look, if we're going to go down this road of putting these imaging cases in, because imaging typically isn't a part of the vast majority of PT's practice, especially back in 2008, we need to make sure we're right and we're accurate. So all these cases, PTs were normally the authors. All these cases were vetted. We had a team of 4 or 5 musculoskeletal fellowship trained radiologists who reviewed all the cases. We would have them submit the radiology reports. They would be reviewed by the radiologist, and they would say, yeah, these captions are a go. So everything is accurate. So it wasn't some Yahoo like me up here yanking images off a scan saying that, yeah, so this is what it is. So these have been vetted. So anyways, interesting case, I thought, because if anything speaks to the relationship between abnormal anatomy and function, it's this case. Because if this woman had low back pain and they did this scan and they showed, right, this L5 on S1, you would automatically say that is definitely the symptom generator. But how can someone walk around with that in their back, right? That's very interesting to be pain-free for the last 7 years. So what they did, this last paragraph here, they call it a prophylactic cesarean section. So they took her to the OR under very controlled conditions, general anesthesia, and delivered the baby right through that cesarean section. The OB doctor said, there's no way I'm going to put her through the trauma of childbirth because I don't know what's going to happen. And again, the pain management staff said because of the position of the nerve roots in relation to the spine, that we're not going to try even putting a needle in there. We're not going to try and do that because the chances of a complication are going to be so high. Last thing I'll mention is that you might say, I don't know if I would have did that, right? I don't know if I would have did that. Another take-home message is that we know that patients tell us a lot. They tell us a lot more than probably they share to other groups. Lots of reasons for that. We have more time with them. PTs, typically, we just did satisfaction rates for a bunch of hospitals. PTs are off the charts. They hammer everybody. They like you guys. They're satisfied with your care, and they trust you. So they tell you things that other people might need to know, but they don't know. So anytime you're getting information, right, think about the downstream effect that information might have. Maybe not on you. You don't care how the baby's delivered. Why would you care how her pain management goes? But somebody else might, based upon just your knowledge of that spondylolisthesis and the abnormal anatomy there. Last thing I'll mention, that reference down there. So, she shows up 6 months later. Baby, husband's there. They bring you that nice basket. If you're a good PT, you guys know, you get that nice basket. There's a bottle of white, a bottle of red, the good pepperoni, right? The good pepperoni, not the stuff that you get from, the convenience stores, good cheese, water crackers, the whole 9 yards. Thank you so much for everything that you did. We're so happy. Everything is going great. Not having any pain, by the way, not having any pain. They said, well, can we talk? Yeah. So the PT, I talked to the PT about it. Yeah. So we talked, sat down and talked, and they asked $1 million question. Well, I'll tell you what the question was. So the husband was concerned about this and did some digging. So she's seen 2 neurosurgeons. One said, leave it alone. The other one said, fix it, right? The other one said, fix it. Then they ask you, what would you do, right? And that's the time when I normally say, you know what? I got to go to the bathroom real quick and head out and figure out what I'm going to say. But we put that reference down there because in these patients who have these high grade slippages, probably a grade 2 or more, but they're not having symptoms that are a surgical emergency, right? So they're not having cauda equina, because that could happen. I'll talk about that in a second, right? You leave this alone. And we talked to a neurosurgeon about this particular case in these high grade slips. He said, number one, these nerve roots are going to be adhered down. And it's probably going to take 2 to 3 hours. And it's going to be very, 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 very delicate surgical dissection to clean all that up. This is essentially fused. You're going to have to break that off and pull that back. All kinds of risk for complications, unless she's having surgical emergency type symptoms. So bowel and bladder issues, saddle paresthesia, significant weakness in her lower extremities. And I mentioned before, I'll close on this. And so bottom line was the data in that study said, leave this alone. I think she went that route. But, I mentioned that unless the patient has a concern for these sinister conditions, you can talk all this stuff down. But at some point, she has to know you're at risk for cauda equina. You're at risk for this disorder that could affect your bowel and bladder function, could affect your muscles in your legs, could affect your ability to walk. And if that ever should happen, what's the time frame that she has to be seen? It's ASAP, right? We know from the military and all the traumas that a lot of military soldiers and folks had that you probably have max of 48 hours once this stuff comes on in order to fix it surgically and hopefully get good recovery. So, normal patient, I wouldn't say that stuff too, but this type of patient goes against all that back book stuff, right? Because she needs to know that this stuff could happen down the road. And if it does, you have to be seen by somebody ASAP. All right. Very good. I said I'd leave 10 minutes. I'm going to leave 6 minutes per questions. So I'm going to stop sharing that. I'm going to check what the chat has to say. Imaging tells you nothing. Absolutely. Typical orthopedic physicians do not test how loads affect the tissues they're evaluating. I'd agree with that, Prax PT. Thank you for that statement. That's outstanding. Does anyone know if the practice of reviewing imaging by physicians in the ER setting without patient contact is becoming more prevalent? That's a great question. So if I get that right, practice of reviewing imaging by physicians in an ER setting without patient contact is becoming more prevalent. I think it's prevalent all the time. And I'll tell you, I have a physician friend of mine who was a PT. And I'll close on this little story here. He was a PT, went back to medical school, became a radiologist. Stud radiologist hanging out at a level 1 trauma center. I'm not going to say the city. But he moved his office from the radio. So he used to work these 12-hour shifts, right? And he would work the 12 a.m. to the 12 p.m. shifts. You'd get all the weird stuff that goes on in the middle of the night. And just like with little kids, projectile vomiting never happens 2 o'clock on a beautiful Sunday. It happens at 2 o'clock in the morning when it's dark and the power's out, and all that crazy stuff happens at night. So he actually moved his office from the radiology suite to the emergency department. So when he got reports from physicians, right, rule out CVA, right, in this patient, normal neuro exam, and he'd walk in the room, half the patient's face would be drooping. They can't move their left arm. You just told me you have a normal neuro exam, right? So in their mind, this guy, PT, had to examine a patient before he could make a call on some of these patients in the ER. So he moved his office down to the emergency department. He also said something kind of interesting to me. He goes, now that I know after going to medical school, I would never ever see a patient direct access. And I would never want to order diagnostic imaging or prescribe meds. Because you could imagine what you learn in medical school, because we're just kind of scratched the surface on some of that stuff in PT. We think we know a lot, but we probably don't. How have physician groups responded by your provided data about utilization of PTs? I think Bob made a good point. There are some physicians out there that are very, very worried about their turf. And, I had this conversation with a PT recently. Why is the military kind of squared away? There's no profit, right? Orthopedic surgeon is not being paid based upon the number of cases that they do. Same thing with a neurosurgeon. So they're a little bit more parsimonious in how they do business. Once you get to a for-profit model, everything starts to change. And if you start giving PTs direct access with imaging, Hell, now they can manage a patient soup to nuts. And they don't need you anymore. And some people are a little bit put off by that. I'll just say it that way. But we're gaining lots of traction on these states, and I'm telling you, they're going to continue to get them. And we're looking at the outcomes of these groups, and they're good. The key is you have to have physicians on your side, though, right? So you have to have physicians on your side. And I tell all of our grads, if you start to practice and you don't have a physician that you can text with or a PA or somebody you can bounce questions off of, you're doing yourself a disservice because there's a time and a place that we have to have those folks. But I would agree, Dustin. I think you're going to get physician groups that are just not going to buy into it, and they're going to question our training. They're going to question PA and nurses training that you saw the letter from the American College of Radiology appropriateness criteria, and so I think that I think it's interesting. Zach, progression of imaging referrals in states. Yeah. So Zach, there's a couple ways we can go about that. So in some of these states, you can just like New York, you can just try and do it and see if you get reimbursed. But if you know our Practice Act, as I know that you do, if we see patients direct access, we have to have them sign a waiver saying that they may not be paid for this. New York State is terrible. And we are working behind the scenes, a couple things I know that I can't share. But right now, if it's silent, you can try it out and see. But our recommendation is that you use that same form when we see patients direct access, that they sign it saying that your insurance company may not cover these visits, right? We get those 10 visits over 30 days, right? Beyond that, they have to see a physician. But, we still recommend that because if you send a patient for imaging and they say a PT sent you, let's say they order it, but the insurance company says, well, a PT ordered it, we're not going to pay it. Patient needs to know that could possibly happen. I don't see it happen a lot, though. I don't see it happen a lot. Great question, though. All right. Very good. All right. So let me post the link for the Google form. Okay. And then you guys can it literally is going to take you 30 seconds to do it. But that way we can get you guys your appropriate certificates. If you say, I don't want a certificate, that's perfectly fine. You don't have to do it, but let me post this in here. And all you'll do is just copy and paste this into your browser. So I'll set that. I'm just going to hit this real quick to make sure this shows up. Oh, I sent it to Ashley accidentally. Sorry, Ashley. I'm going to direct message. I got to send it to the entire group. I got to send it to the meeting group chat. Here we go. Paste. There we go. So I'm just going to click it, see, open the link. Yeah, it should pop up. It'll say thank you for attending and just provide your info. What we need is the state. There's a Dropbox for that. So then we'll take care of it. If you guys are from Wyoming or Arizona, give me a day or two to get the list over to Krista. You guys can get your certificates through her. And then if you're from a state outside of those, I'll provide one for all of you. Very good. Nice sized group and good participation. Really, really good comments. I really appreciate the chance to talk about this. I think these really turn into kind of more, what probably is good PT, right? And how we can look at those imaging findings and everything else with the patient, put everything together in context and really help them understand what's going on. I showed you that one study that looked at outcomes because it's so powerful when patients really are educated and we have the skills and knowledge to do it. Plus, we know how to treat them, meaning in terms of manual therapeutic exercise, if we need to do psychologically informed stuff, because lots of times patients are scared. So very good with everything. I'm going to go ahead and sign off. I will get the recording to Krista as well. And if anybody wants the slides, I'll type my email in here real quick so you guys can have that. I'll put that in there. So if anybody wants to contact me, I'm sending it to, there's my email, mross@Damon. You too, Zach. Best of everything to you. Go Navy, beat Army. Oh, you got a little Army Navy thing going in there. That should be good. That's always a great game. You just throw the records out the window, Bob. That's all I can say. And I think that's for the Commander in Chief Cup too, isn't it? Or trophy. Where's the link? So I put that in there. I'll put the link in again. Here's the link. Rebecca, can you see it? Jane, just fill out the form.
Yes. Yes.
Just fill out the form. And we didn't put Canada on there, but just put after your email, put Canada, okay? And I'll remember that. Just put a space and put Canada. Okie doke. Right. All righty, guys. I'm going to sign off. If you have any questions, let me know. But thanks again for your participation. Thanks for the chance to be here. If we are in Wyoming, do we automatically get our certificate? Yes, you will. Go ahead and click. Go ahead and click the first state, Jane. That's on there. That'll be fine. Yeah, just click the first state. Just after your email, just put a dash in Canada, and I'll make sure we get your certificate to you, though. All righty, guys. Have a great evening. Go Bills. Bye.